Coming up today, tiny radioactive beads deposited in your liver. What the less invasive cancer treatment means for someone who's been living with her disease for years. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. A metastatic breast cancer diagnosis can feel like a ticking clock, but advances in treatment are letting more patients live longer, fuller lives, even with a stage 4 diagnosis. Cammy has lived with breast cancer for a decade, and she's been living life well. But when she found out the cancer had spread to her liver, she also found out about a procedure that delivers radioactive beads directly to her tumor, leaving behind only a Band-Aid. Cammy is with us in studio today alongside palliative care Dr. Ben Skoke and also interventional radiologist Brandon Custer, both working here at the University of Kansas Health System. Good morning to all of you.
Morning.
Good to see you all on this Monday morning. Our most loyal viewers might recognize Cammy. You've been on our program twice before, so you're a frequent flyer here, and we're so glad to have you back. Before we discuss this new chapter involving your liver, because you were before talking about your breast cancer journey, let's recap your story. Previously, you talked about the good that came out of your cancer diagnosis. When you talk about the good, what are you referring to?
Well, this past decade is a surprise, was a total surprise for me, not at all what I had planned for my life. We can't often control the circumstances we find ourselves in, but we can control how we choose to deal with them. And so when I came face to face with death, I thought I wanted to look at my priorities and kind of re-examine, and I decided to put God and people at the top of the list, and decided to let go of little annoyances and frustrations that bother us each day. Decided to say I thank you and love you more often. Decided to be more forgiving. And also I started noticing little beauty in each day that I would have been too busy to notice, and I'm just grateful for each morning.
Well, we've been so blessed just to have you here sharing your story. And two of your people are Dr. Custer and Dr. Skoke. And how great is it, Dr. Custer, I'll start with you, just to be here with Cammy and just being a part of her life.
Yeah, well, it's great to have patients that are have such a great mindset going forward with life and trying to help them in any way we can.
Dr. Skoke, I know you've created quite a bond with Cammy.
Yeah, it's been really wonderful. She actually asked to come see us. I was recounting in our notes, just sort of gearing up for today, and she has been a highlight on the schedule ever since.
You look forward to those visits, I bet.
Absolutely.
I bet. Well, when some people hear words like stage 4 or metastatic or incurable, they often imagine someone lying in their deathbed, maybe counting down the days of their life. Cammy, how often do you get kind of a shocked reaction when people see you out living, enjoying life, having this positive mindset, and then you tell them you have stage 4 cancer?
Oh, often. I mean, I maybe don't tell them, but my husband does, and they're like, they can't believe it, But he says, I see her at home. And honestly, the last couple years, it's gotten to the point where for every day that I'm up and out, there's a day at home. But, that's just the way it is.
So it's not sunshine and roses all the time.
No,
you admit you have some rough days.
I do.
But you really try to appreciate the good days.
For sure.
Dr. Skoke, palliative care is often misunderstood. Because I want to talk about this. People think it's only for end of life. Can you explain its real purpose, how it fits into cancer care for your patients?
You bet. And just to normalize a little bit, I think there's rightfully some confusion. The training program, the fellowship that I did was hospice and palliative care, and so a lot of people will come thinking they're meeting with hospice and those types of things. But as new cancer treatments have become available and people are living for decades or longer, we've just recognized the need to be with people, walk with people on their journey as they go through their cancer treatment. And so I think that's what we really strive to do in the palliative care clinic, especially in the palliative oncology group. We work with people like Cammy and try to make their good days as good as they can be, and the bad days, a little bit better. And just has been really rewarding to walk alongside people on their cancer journey.
Such a special field to get into. What made you get into palliative care?
Probably mostly divine intervention. It sort of found me. I trained at a program during my residency that didn't have structured palliative care, and so wound up kind of having a lot of these conversations, walking with people, realizing there's just big gaps in care when people have serious illness, and really found a heart to be with folks along their journey, and have never looked back. I really enjoyed, and certainly the people working in palliative care, I'd be remiss if I didn't mention Annie, my clinic nurse I work closely with, and she's obviously been a wonderful asset, a blessing to our patients.
Yes.
Cammy, how has palliative care helped you?
So much. I mean, after being on nonstop chemo now since January 2020, 5+ years, it just wreaks havoc to the body. So it's symptom management is why I first came to see Dr. Skok, and so I specifically got help from him for bowel, insomnia, and anxiety help, I think. So just to, we were able to talk through these issues and how can I deal with them better. And also, then he helped me to plan what hospice I will choose when that time comes. So that was a great help for me too. And so that's just to name a little bit. So.
Yeah, and I think just about the hospice piece, I think part of having good quality of life and really feeling secure with where you're at is having a plan for kind of the what ifs. And Cammy sort of brought this to me and said, I just really want to know sort of when we get to that point, what does that look like? And just kind of normalize some of that conversation. And I think you brought a whole binder or a packet to us about questions and information we just sort of helped you work through. And again, applaud you, because that was a lot of the heavy lifting done by you. So
getting that conversation out of the way so she can get back to living life.
Yes,
you bet.
Exactly.
So Cammy, at some point you learned that the cancer though had spread to your liver. How much had it spread? When did you learn this too?
Well, when I was diagnosed metastatic in January 2020, there were spots on the liver at that point, but they stayed pretty stable until December of last year, and that's when my CT showed that they had doubled in, I think the way that it was described, doubled in size and number.
Dr. Custer, this is where you come in and get involved with Cammy's care. When cancer spreads to the liver, there are different treatment options. In Cammy's case, she received a kind of radiation called Y90 radioembolization. How does that work? Explain that a little bit.
Yeah, so what this is, so my whole profession is putting catheters into blood vessels and using X-ray to guide them around the body. For this, we get access to a small blood vessel in the groin, and we use X-ray to guide that catheter up into the liver, where we can take pictures with a contrast dye. What we do is we identify which actual blood vessels in the liver are the ones supplying the spots for the tumors. Once we've done some things to prove exactly which vessels those are and that it's safe to give you a treatment, we kind of tailor a radiation dose specific to the patient. And then we'll inject these small beads that really just act as a vessel to carry radiation into the tumor cells. The flow from the blood actually carries those beads deep into the tumors where they lodge in the cells. And then we have a really, really cool radiation. When a lot of people think of radiation, they think of radiation beam from outside their body. Our radiation only goes a couple millimeters in tissue, which means when we lodge it in that tumor, it stays there, kills the tumor, but doesn't hurt other parts of your body. And what that radiation does is it causes breaks in the DNA that eventually causes the cells to die, and then over time those tumors will shrink up, and we'll have control of those tumor spots in the liver.
What are those beads made of?
So there's two different kind of flavors of Y90. One of them is made out of little glass spheres, and the other one is made of a resin material, kind of a plasticky material. They're all microscopic beads, though. Sometimes when people hear beads, they think there's something that is like a tangible bead. Yeah. It's not. These are at the cellular level, so you can't really see them or anything.
Very cool, though, to see this animation and watch that happen in real time. So this is not an open surgery. Does the patient stay awake and watch this as it's happening?
Yeah. One thing that's nice about what I do is everything we do is minimally invasive, so we don't have to do a whole bunch of real deep sedation. So we do give people medicines to take away pain and anxiety during our procedure. They should be comfortable. They should be arousable though, so they don't have to go under all the way asleep. We don't have to put tubes down their throats to help them breathe or anything like that. It's all usually done as an outpatient, so they come in that morning, leave that same day. There's no hospital stay or anything like that.
Cammy, what was the experience like for you? Did you watch the procedure? And
Well, I'm always so curious in procedure rooms now, and so I was a little drowsy where I could have taken a nap, but I just wanted to watch and see what was going on. And so I was actually in the procedure room 3 times. Dr. Custer did the mapping. I think that's what took the longest, and then I was in the next day for to do the Y90 on my right lobe of my liver. Then a month later for the left lobe.
Yeah.
So that third time I said, could I wear my glasses? And they're like, sure. So I actually did watch the screen then, and I just found it fascinating.
how could you not?
I know,
I'd want to be
right?
in there learning all I can. You mentioned mapping. What is mapping?
Yeah, so it's just like she describes, the treatments are a 3-step process. So the first step is really the one that is the most involved for us because we do all of our planning during this thing we call the mapping procedure. What we do is we go in and we really evaluate the blood flow to the tumors and try to figure out exactly where we're going to treat you and how we're going to treat you, and then tailor a radiation dose specific to each patient using that information. Then we also want to make sure that we don't see any potential things that could cause complications. The most common complication that we're trying to avoid is beads going somewhere other than tumor because they're powerful, but they kill whatever they hit. So if they go somewhere other than tumor, they could cause problems. So we look for those blood vessels as well during that mapping procedure. And then during that mapping procedure, we'll inject some little proteins that are about the same size as the beads that have a special signal we can see on a scanner, and we just use that to double check that everything's going where we want it to go.
Dr. Custer, you brought some scans of an example case. Just to clarify, these are not images of Cammy, but this patient had a liver mass that was so big you could see it pressing against their abdomen. So,
Yeah.
so tell us what we're seeing here.
Yeah, this is a pretty remarkable case. And again, this isn't Cammy, but I thought this was seeing it on this would be a lot easier for people to kind of digest as an audience. So you can see that red circle there on our screen. That is a large enhancing mass. And you see how it's a little bit brighter than a lot of the other tissues around it. That's what we see when something's alive. And then on that right picture, you can see where the mass is actually pushing out the belly. You see that kind of where it's pushing out on this person's belly. It was causing a lot of pain. And this was a person who was also someone who we were treating palliatively to try to get control of this disease, but also to try to treat this pain if we can shrink it up. So we decided to treat this person with Y90, very similar to Ms. Crank's.
Then you said in the contrast dye.
Yeah, so this is our mapping procedure that we were talking about before. So we have a catheter up in the blood vessels, and we're injecting contrast here, and we're showing that this is a good vessel that's supplying a lot of the tumor. So that black stuff you see coming in and then branching is a hepatic artery, and that, without having a normal to know about, it can be hard to tell, but this is what a tumor vessel looks like, and we can kind of confirm that's where we're going to give our injection. So during this mapping, this is where we would give in those little particles that give off a special signal, so we can confirm where they're going to go on this scan. So you see all those bright marks, that's all around that tumor. That's where we are confirming that it's going to go to the right spot. Then, like she said, she usually come back the next day for our first treatment, where we'll go in and prove that, where we've already proven that it's safe, and we'll give the treatment at that point.
And then we have another slide, more
And
color.
this is from the treatment. This shows exactly where all our beads went and killed everything.
And then there's a before and after.
Yeah, so on this person, it had a really remarkable response where they had that big red tumor that was pushing out on the belly, and afterwards it all shrank down into that posterior part there where that red circle is, and you can see no more stuff pushing out forward on the front of the belly. So almost complete resolution of their symptoms, which was really our biggest goal.
And how did Cammy's tumors respond?
Well, so we're still getting to that point. So we're pretty early on in the process for her. So we can't scan. Our first time point to kind of measure how we did is 2 to 3 months after the treatment, which we're just not quite there yet with her. So we'll see here in about a few weeks now. Yeah.
How much pain were you in?
Oh, there was no pain except at the very beginning, when just very slight when they entered the artery.
But what about when you were, when you were having with the liver pain? Were you feeling?
Oh, beforehand.
Yeah, beforehand.
Yes. I would have different jabs or different, pain with it. Girl, I asked my oncologist. I said, "Is this a liver tumors?" And he said, "Probably."
Dr. Custer, how often is a palliative care patient ineligible for surgery, but they are a candidate for a catheter-based procedure? So what would disqualify them from open surgery?
Yeah, well, I see most of the time when you're at the point of being a palliative person, when you're talking specific to the liver tumors, you're no longer a surgical candidate. Usually they reserve, in almost all situations, they reserve surgeries on the liver to people that are curative intent, that we're trying to actually get rid of their only site of disease or give them a transplant or something like that. So once you are in that palliative category, you're probably not a surgical candidate anymore, and most of those patients will come to us if they have spots in their liver that are their only sites of disease, or in Cammy's case where that was this place where the systemic chemotherapy wasn't controlling the disease anymore. That's where we saw growth. Or if we think the liver disease is the thing that's going to limit the length or quality of someone's life, then we're going to go over and try to get control of that disease.
Cammy, outside of Y90, did you get any other treatment for the liver metastases?
Well, since my cancer metastasized, I've been on chemo, which does it's systemic and it goes through the whole body. So it had been working on the liver, but just stopped. So.
Well, your questions are a crucial part of this program, and we love having them answered by our experts in real time. So please use the chat on YouTube or Facebook. You can email the Medical News Network, and you can find that information right there on your screen. Cammy, I have to ask you, how have you kept your mental health intact through all of this? And do you see a therapist?
Yes. So I see an onco psychologist here, Dr. Marcus Alt, and I was referred to him when my cancer metastasized, and he was great to kind of walk me through different things I might go through, get into terminal diagnosis, and he helped me with the end of life notebook. Actually, it's kind of like I would use you and him both, and I couldn't quite sometimes figure out where one would start and the other would end. And also, I have to say, too, my faith in the Word of God have been a great source of help and comfort to me through
I would
this,
imagine.
too.
I would imagine they work hand in hand. Dr. Skog, is there an overlap between palliative care and psychology and therapy, and how does that all work together?
Yep, I think just to Cammy's point, several of our patients sort of go to both, and I think there's value in each. I think sometimes those questions just sort of come out as a part of our visit, and so helping people work through the emotions of a serious illness, and just kind of helping them take the mindset that Cammy's adopted so well. We have today, we're going to help you have a good today, and sort of as we alluded to earlier, you kind of hope for the best and plan for the rest. And I think both of our specialties kind of help people navigate those things.
I like that. Cammy, I know you have a real strong network of friends and support. In fact, you have one of your besties here with us today.
Yes.
How important has your circle been?
Oh, yes. You can't do this alone. I first want to say my husband has just been my greatest supporter through this whole thing. In fact, he retired to help with things that need to be done. My daughter is an RN, and she answers all my medical questions, and then the rest of the family, just the love, the laughter, the travel. And then when we get to my friends, like Arletta, who's in the studio, drove me here, just the support they've given, and my walking buddies, prayer support, encouragement, and meals have been so great. I have not done this alone. I've had so many people with me and helping.
Dr. Custer, these catheter-based procedures, that's your specialty, as you had mentioned. They take you all around the body. Last time you were here on our program, we were talking about the knees. Today we're talking about the liver. How fast is this field advancing?
Yeah, it's growing quickly. That's one thing that kind of drew me to it, is it's always been kind of on the cutting edge of developing a lot of new treatment and new technologies and making a lot of new treatments possible. So it's still advancing very, very quickly, and we're always finding new places that we can offer patients treatments that can help, conditions that are sometimes things people would say are minor, like knee pain, but we saw how much it can affect people in other ways, and then as much as treating, cancers in the liver. So there's a wide range of things we get to do.
So how is this going to ultimately help patients down the road, do you think? Overall?
Like Y90 or?
Yeah, just what you're doing.
Yeah, well, so as a whole, our specialty allows minimally invasive treatment options. So a lot of times they come with lower risk profiles than big surgeries. And as we develop more and more of these technologies, whatever disease it is that we're trying to treat, we're getting better and better outcomes. And a lot of our treatments are showing comparable outcomes to surgeries now with the reduced risk profile. So as things continue to grow, that's, I think, everyone's hope is that we can get less invasive, better, more effective treatments. So.
Can we talk about Cammy's book? Not every day your patients write a book, but you did, and we've talked about it before, but I want to talk about it again. Hair Today, Gone Tomorrow. What I lost and gained through breast cancer. I know a big part of your identity was your hair, and so talk to us a little bit about this book and what you really want readers to take from it.
I just want readers to know there's hope. You know, when you first get this diagnosis, you wonder, do I even want to go on? You know, but there is hope. And even though I lost, I think this is the 5th time, my best asset in my hair, there's still life after hair. But also that you're not alone. Don't do this alone. And another thing is, I think God never wastes our pain. You know, there's things we can learn and grow from and help others. I think when we're vulnerable, like in this book, I think, you know, everyone's going through something hard. And I think when we share a little bit, it gives hope for someone else.
I remember we were talking to you about this because through your breast cancer journey and going through mastectomies and losing hair, what might be some of your best advice for a woman who is at the beginning of this journey? What might you tell her?
I would say there's don't be alone. I also would say it was embarrassing. And I think that don't be embarrassed. Go ahead and share it. Because I think when you share your burden, then you don't feel so alone. Because it's easy to hide it, especially breast cancer. It's just embarrassing to say anything about it. And I think that's what I would say. And there's hope. I mean, there is hope. And even though your life, like I said, this last decade has been not at all what I would have written for my life, but my life is richer from it. Isn't that odd? Like when I finished the book, there were 10 chapters, and it was when I had beat cancer. But before it got to publication, my cancer came back. So then my son is like, you need to write 2 more chapters, you know. Now, you know, how I found out I had cancer, and then now what? And as we rewrote and then kind of writing through the other ones again, he said, I kind of see, Mom, that you're having like a lesson, what you learned in each of these. Let's draw that out. And then honestly, the book started at more like, this is what cancer took from me. But when I got my terminal diagnosis, that's when I could see what cancer gave to me. And then just the fullness of life, and then so many people, like I'm on groups, metastatic groups, and just being able to help each other. You know, my life is so rich because of this. Isn't that odd? You know, you would think if your life is all just great, you know, and perfect, that's when you would just have this wonderful life. But I've gotten a wonderful life out of this terrible diagnosis.
This book is a gift. This is a gift. It's sat on my desk ever since you gave it to me. And this is now the 3rd time you've been on. And I want you to come back. I want you to keep coming back. That's where the hope is. You kept writing more chapters and you keep coming back, and that's what we love about you. Let's get to some questions from our viewers this morning. Stuart wants to know, Dr. Skoke, how blurry is the line between terminal illness and chronic illness?
What a good question. Lots of blur. I think, you know, in palliative care, people have kind of a life-limiting illness, I would say. Sometimes it's hard to sort of put a time or a prognosis on people. Obviously, you know, people can have even stage 4 cancer and live for years, sometimes based on what treatments are available and those sorts of things. So, you know, especially palliative care is a growing field. There's just not enough palliative care providers to provide that service for everybody who has even a life-limiting illness, or certainly any chronic illness is so common in our country. So some of it has to do with resource availability as far as the people who we're able to see, and then especially here at KU, we have, you know, like I said, the palliative oncology group. We have palliative care physicians and practitioners in heart failure and some neurology clinics, so a little of it's disease specific, but yeah, definitely some overlap. And I suppose if there's a question like who's eligible for palliative care, you could ask your primary team, your cancer doctor, just have questions and they can help point you in the right
But
direction.
I like that it's not so black and white.
Yeah.
That's actually kind of good news, that it's just not one thing or another, that
bet.
people sit on different parts of the spectrum there. So Jeremy has a question. Are those radioactive beads, Dr. Custer, useful for lots of cancers, or is it mostly on certain types?
Yeah, so there's variability in the response a little bit. These are things that we can only inject right now into the liver tumors. So it's only going to be people who have primary liver cancers, a cancer that's a liver cells that started in the liver and is in other places, or metastatic disease to the liver. We can't use it now currently on any other sites of disease anywhere in the body. But as far as what type of spread, like is it breast cancer or colon cancer that gets to the liver, usually there's data for basically any type of metastatic spread to the liver that there's at least going to be some response, but there is some variability about how well each tumor type responds.
Amy wants to know, can someone get the Y90 treatment more than once?
Yeah, so there's only a few things that limit the ability to do it how many times, and almost everybody can get it more than once, but there are lifetime dose limits to how much radiation you can get to your whole body and to your lungs, and those things can limit us on some people eventually, but usually it's after multiple treatments. When
should someone seek out palliative care?
Our old adage is any age at any stage, so I kind of like to consider us the quality of life team. If you feel like you have a disease process that's adversely affecting your quality of life, those are things that we want to be helpful with. Yeah, and anything that's, if you have a life-limiting illness, certainly, and if you have symptoms from that, or maybe have a hard time talking with your family about it or something like that, those are kind of the things that we do. In general, the three big things, I think I probably said these words to you when we sat down our first visit. We do a lot of stuff, but the big three are symptom management, communication, especially in a big system like KU. We help sort of coordinate a lot of moving parts, and then work with patients and their families based on their disease and the treatment options that are available to help them figure out sort of what are their overarching goals of care.
Dr. Skoke, on a palliative care perspective, what do you want the big takeaway today to be?
Well, a couple things. One, it's just nice to be sitting next to Cammy. Have really enjoyed all of our time together, and that includes today. And then big thanks to Dr. Custer. I was sort of just taking a look at, what to talk about today, and realize you do a lot of palliative care between Y90 and sometimes tubes and bellies and these sorts of things. So especially grateful to you and your team. And then from my perspective, just maybe the first point, it's not just for people at the end, and was reflecting with Cammy, we're coming up on our 2-year palliversary, so our palliative anniversary, and just want to help people celebrate each year, month, and day that they have. So I think that's the big thing.
Palliversary.
I'm going to make it a thing.
That is a thing. I love this. That's like bumper sticker stuff. I love it. All right, Dr. Custer, beat that.
That's going to be tough.
That's tough. Okay.
I'm going to piggyback on it a little bit. So just want people to know that just because we say we're going to treat something palliatively or with palliative intent, it doesn't mean we're not going to be aggressive on trying to control their disease as much as possible.
Yeah.
Sometimes people, when they hear those words, they think we're not going to be giving it our all. And we still have a lot of things that we can be very aggressive at treating, even when we know that studies would say it's not going to be a cure. It's unlikely something's going to be a cure, but doesn't mean we're not being aggressive at treating something as much as we can. And then for people outside the KU system who might be seeing this, if you have, metastatic disease that you have in your liver, or you have a primary liver cancer, not all places are as knowledgeable about these types of treatments. So be your own advocate, and we're always welcoming people to reach out to us if they think that we might be able to help them.
I love that message. After what Dr. Skoke said, you said we're going after it hardcore. I like that. That's a really great way of looking at it. Okay, Cammy, you're going to wrap us up today. What is the big message? What's the big takeaway from your story?
Oh, well, I mean, I have so much help. I mean, these and like when I saw Dr. Custer the first time, I felt like he really cared about getting rid of the cancer in my liver. And there's so much help out there. And I've had the privilege of meeting several KU researchers that research breast cancer. And there's always something on the horizon. So there's always hope. And I just want to say, you know, I might be dying, or a listener might be dying of metastatic breast cancer, but we need to remember that we're also living with metastatic breast cancer.
Well, we're all dying, but you're living really great, and I love it when you're here. So thank you so much for getting our week started out great. Love it when you're here. Thank you. Thank all of you for being here. You guys are great. Thank you so much. Thanks to all of our viewers for being here too. Have a great Monday, and we'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update. Life after transplant isn't always life as it used to be. I'm Jessica Lovell on the next Morning Medical Update. A young woman learns she's a warrior, how her mind and body battled setback after setback. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.